is repeated implantation failure. We haven't yet defined what is repeated implantation failure, and it is urgently needed a consensus meeting that we are organizing already in SRF to define what is repeated implantation failure. So, how many attempts must a couple to do in order to be included in the repeated implantation failure? How many embryos has to be put back inside the uterus? What is the age of the woman? What is the quality of the embryo and the failure in the presence of potential obstacles? Until now, what has been thought to be repeated implantation failure is the failure to achieve a pregnancy after 3 completed fresh IVF embryo transfer cycles, or the failure after in total more than 10 good quality embryos that they were unable to implant. And of course, in the era of the single embryo transfer, the definition of RIP should be revised. Now, let me tell you why should implantation fail to take place. And we know that implantation is actually a key event in the establishment of pregnancy. We have 3 stages. We have the apposition of the embryo inside the uterine cavity that comes and adhere in the epithelial cells, and then we have the invasion after the breaking down of the epithelial cells and the beginning of invading the extravillous stromoplast inside the stoma. And this, what is really important to understand, that implantation, it is a continuous process from conception to 22 weeks of gestation. So it is not a matter of a couple of days, but it's 22 weeks. Now, in order to understand how implantation happens and what is really important for the immunology of implantation, successful implantation is considered when the extravillous trophoblast, they start to invade inside the stroma in order to come to the spiral arteries to replace the endothelial cells in order to form the hypochorial placenta, what I was mentioning before, that this is in the junctional zone. If this replacement is successful, then the implantation is successful. If it is not, we have the different problems like that infertility, miscarriages, preeclampsia. Now, what is important to understand that during this journey from the extravillous trophoblast, as they come to the spiral arteries, they come in contact here with many immune cells in the stroma, like it is the dendritic cells, the activated T lymphocytes, the macrophages, and through this interaction we have the productions of different cytokines. So we have a microenvironment here in the implantation site that, depending on what kind of cytokines are produced, we can have a microenvironment that is beneficial for implantation or not. And this has to do with the production of Th1 and Th2 cytokines. So what I will try to show you with the cartoon, that in normal invasion, as the extravillous trophoblasts start to invade, they come in contact with antigen-presenting cells, like it is the dendritic cells that is locally in the area, and they can drive the reaction of the Th cells to the Th2 reaction by mainly producing IL-4 and IL-10, and this is the reaction we have. But most importantly, these IL-4 and IL-10, they block the Th1 reaction, they block the production of interferon gamma, they block the cell-mediated immunity, and this is what is happening in normal invasion and what is successful implantation from the immunological point of view. Now, as clinicians, we have some treatment strategies for recurrent implantation failure. So we have factors that they are attributed either to the embryo or the endometrium. And from the embryo has been proposed in the past that we have to do pre-implantation genetic diagnosis, blastocyst transfer, assisted hatching, co-culture of embryos with endometrium, and other methods that mainly has to do with embryo selection. But what has been evidence-based for women with repeated implantation failure, the only one from all these that seems to be statistically significant difference important for the patient is only the assisted hatching. Neither of the other has been evidence-based that is beneficial for repeated implantation failure. And from the point of endometrium, we know that we have the use of hysteroscopy, or in case that we have hydrosalpinges, that we have to remove the hydrosalpinges. Now, what about the use of IVIG, the only conducted prospective randomized control trial involving 51 women with 2 or more IVF failures show that IVIG is of no benefit. What about steroids? Also, a meta-analysis showed that there is no evidence of benefits by using steroids. What about in case that we have anticardiolipin antibodies? It is showing that even in cases that they are positive for anticardiolipin antibodies, that in these cases the use of heparin and aspirin is of no benefit. And what about aspirin? Also, low dose of aspirin, it is of no benefit in cases of repeated implantation failure. So what are the novel approaches in case that you have a woman, you do assisted hatching in first case, secondly, with hysteroscopy, looking there are hydrosalvages, and after this, what can you do? And so we have 2 questions here. The one is, does the endometrial scratching promote implantation and live birth rates in patients with grief? I will go back 100 years ago, that already in 1907 we had a paper in anatomy. It was showing that mechanical manipulation has been first shown to be associated with residual formation, so we induce residualization in case that they use a kind of scratching in these cases. And of course, you know that we have the first paper about 10 years ago in fertility and sterility, showing that local injury to the endometrium doubles the incidence of successful pregnancies in patients undergoing IVF. And the results, it was showing that they had a significant increase in clinical pregnancy and live birth rate. And the important thing is that this finding was independent of the mode of the embryo transfer. Either they would do day 3 of blastocyst, the results was not of statistical significance. And we have the first meta-analysis by Luciano Nardo in 2012 showing that endometrial injury actually it favors implantation in case it was done either by hysteroscopy or either done by EpiPen, and the endometrial injury improves the live birth rate. And at the same time, a second meta-analysis by another group, that it was also showing almost the same results, that we have an improvement of live birth rate and ongoing pregnancy rate if this was done only by hysteroscopy. Now, in order to summarize the physiological effect, what is really happening in case of scratching, it is that the local injury of the endometrium induces an inflammatory response that promotes successful implantation. So keep this inflammatory response. So we have an aseptic inflammatory reaction when we do the scratching, and these induce the accumulation of macrophages and dendritic cells, that they also induce the Th2 reaction that I was trying to explain in the previous slides. But most importantly is accumulation of the macrophage inflammatory protein 1b. That is really very important because we have an aseptic inflammatory reaction locally in the area. And of course we have the reaction of other molecules important in implantation, like it is osteochondrin. Of course we have a lot of issues to be addressed, which is the best cycle. Until now, evidence support the performance of endometrial biopsy 1 cycle prior to IVF. And it is advisable not to perform the endometrial injury on the day of the oocyte retrieval. We have 3 studies already that appears to significantly reduce the clinical and ongoing pregnancy rates if you do it during the day of the egg collection. And which is the optimal day to perform endometrial biopsy? Most studies support the days 21 to 26 of the menstrual cycle, but the evidence is still weak because we still need studies for this. And so in this cartoon, what you can see is that if you perform the scratching in the previous cycles, you have an accumulation of dendritic cells and macrophages. They produce Th2 in the area, so when the blastocyst is rolling to coming in the area, the microenvironment is full of Th2, and this is very important for the beginning of implantation. And now the second question that we have said in cases of repeated implantation failure is if the use of intrauterine administration of peripheral blood, homologous monocytes, promote implantation and pregnancy rates in cases with repeated implantation failure. We know already that peripheral blood monocytes treated with HCG significantly increase in murine embryos the invasion that is the first publication a couple of years ago. And of course we have a paper in 2006 by the Japanese group that showed that intrauterine administration of autologous peripheral blood monocytes increased the implantation and live birth rates in patients with severe implantation failure, and had a second publication 2011 that intrauterine administration of PBMCs increased the clinical pregnancy rates even in frozen soil embryo transfer cycles in patients that they had repeated implantation failure. And the importance for this is that this kind of technique significantly improved the implantation and clinical pregnancy rate when it was in women that they had 3 or more implantation failures. If it was less than 3 implantation failures, the results, it was not statistically significant. The proposed mechanism for this action, it is also the same like the scratching, that the PBMCs can evoke favorable inflammatory reactions. So actually, we induce the inflammatory phenomena locally in the area, either by doing scratching or by using PBMCs. And in that way, by using the inflammatory reactions, we also affecting the secreting proteases inside the uterine cavity, that they affect all kinds of surface molecules inside. So issues to be addressed: what is the biological impact, when is the appropriate time to administer the PBMCs, should be pre-treated with HCG, and most importantly, if there is differential or better activation of the PBMCs. And in this kind of questions, we put this hypothesis that maybe the use of the intrauterine administration of PBMCs, if it is pre-treated with a hormone of inflammation, because as I mentioned before, we have an aseptic inflammatory reaction. So why don't we pre-treat the PBMCs with the hormone of inflammation? Wherever is inflammation is the corticotropin releasing hormone. So if you pre-treat it, maybe you can increase the pregnancy rates. We have a background on this. We published already many years ago that the implantation sites in the right uterus contains increased concentrations of the hormone of inflammation, that is CRH, and we publish in Nature that, or actually this corticotropin releasing hormone promotes blastocyst implantation and early maternal tolerance. So we know from the physiology that is really very important. So in order to come to this, we just published a month ago that in repeated implantation failure, the results that I'm going to show in the next 2 minutes, that actually in cases that they have more than 3 repeated implantation failure, we took during the day of the egg collection peripheral blood monocytes, we pre-treated with the hormone of inflammation with CRH, and then we perform blastocyst transfer. Here is the clinical characteristics of the leaf woman that is equal in this case with more than 3 repeated implantation failures, and the results about the clinical pregnancy rates from 2.5 to 44.8%. And here I'm showing that from all the studies, this is the biggest study that has been done by treated with CRH, and the results is really, really very good. So does intrauterine administration of PBMCs pre-treated with the hormone of inflammation promote implantations? The answer is yes, and possible explanations, because always we like to do the physiology behind it, is that this hormone of inflammation added to the PBMCs increase the IL-6, that is the Th2 cytokine, and decrease the interferon gamma. And also by looking the expression of the hormone of inflammation from the oocyte to the embryo, we can see that the human embryo is expressed, and most importantly, it is expressed also in the receptor, the CRH1 receptor. So we have an autocrine effect for the development also of the good quality of embryos. And furthermore, in the past we have shown that this hormone induced decidualization, that is really very important for inflammation and the induction of prostaglandin E2. So in conclusion, it is that the local endometrial injury, the scratching, or the use of peripheral blood monocytes pre-treated with the hormone of inflammation may improve pregnancy outcomes in women with unexplained repeated implantation failure. How it works, not entirely known, but as I mentioned, we have an induction of the aseptic inflammatory phenomena during the window of implantation inside the uterine cavity locally. That is really very important. Of course, we have to use this under approved clinical trials with appropriate patient consent, and what is the most important is the need for appropriate randomized trials compare the standardized research interventions with no intervention in a well-defined repeated implantation failure population. Thank you.